अनम्यूट कर लीजिए, अनम्यूट कर लीजिए।
गुड इवनिंग सर, मेरा प्रणाम।
ये डॉक्टर तिवारी सर हैड जस्ट ज्वाइंड perhaps।
कहाँ हैं सर?
हाँ, ही हैड ज्वाइंड, अभी अभी तो देखा उनको। और अभी हमारे जो है ऑनरेबल डेलीगेट सब जो है वो लोग ज्वाइन करें ना।
सो डेलीगेट्स भी इसी लिंक पे ज्वाइन करेंगे क्या?
सब लोग ज्वाइन करें। बट चेहरा चेहरा केवल आप ही का दिखेगा।
चेहरा से ज्यादा इम्पोर्टेंट है कि सेशन में लोग का इंटरेस्ट रहे और कुछ लोग सीख के जाएं। हम भी सीखें और सब लोग भी सीखें। ये तो आपने जबरदस्त इनिशिएटिव लिया है सर, रेस्पिरेटरी का। अगर सब लोग पूरा ये वेबिनार जो कंप्लीट सीरीज केवल अटेंड कर लेना,
हाँ,
तो रेस्पिरेटरी का समझिए कि ऑलमोस्ट कंप्लीट कवरेज है।
तुम लोग के वर्चुअली वी हैव कवर्ड 3/4 ऑलमोस्ट।
हाँ
टू कवर 3/4 सर। अब तो जस्ट ये इमरजेंसी रेस्पिरेटरी मेडिसिन। वेलकम सर, प्रणाम सर।
प्रणाम
प्रणाम
सर।
प्रणाम 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 प्रणाम।
प्रणाम प्रणाम सर।
खुश रहिए, खुश रहिए, खुश रहिए।
Sir, everybody was searching where is Dr. Madhukar in the series.
नहीं, ऐसा आप, ऐसा नहीं है सर। लाइक मालूम था कि आप हैं तो हम हैं ही वहाँ।
We are just part of the respiratory family,
हाँ सर।
medicine family, but because respiratory medicine is also part of the internal medicine.
यस,
Yeah.
करेक्ट सर।
Or the proposition of Dr. Kamlesh Tiwari sir is that we should have the super specialty in internal medicine rather than the respiratory cardio. And that is a very good suggestion or proposition that training of every part of the internal medicine, specialty training, is a must if we want to improve the Medicare of the general patients.
और
Not
सर
in,
वैसे भी सर, सुपर स्पेशलिस्ट इज नॉट इवन ए स्पेशलिस्ट इफ ही डजंट नो द इंटरनल मेडिसिन। इंटरनल मेडिसिन तो सर बैकबोन है, उसके बिना तो कुछ हो ही नहीं सकता।
internal medicine, clinical medicine.
हाँ, क्लिनिकल
You
मेडिसिन।
can launch to anything.
Yeah, this is the difference. Few people are thinking that they are a specialist. They are not doctors, they are a specialist. That is the problem. That's why I have raised this point, that there should be a DM degree in internal medicine as well.
तब तो सर एमबीबीएस के बाद ही बाइफरकेट करना पड़ेगा कि मेरे को इंटरनल मेडिसिन ही चाहिए। और अगर एमबीबीएस के बाद इंटरनल मेडिसिन में डीएम होने लगा तो सबसे ज्यादा सीट का मारा मारी इसी में हो जाएगा सर। डीएम इंटरनल मेडिसिन ये सबसे ज्यादा डिमांड में आ जाएगा।
ये होना चाहिए ही ना जी।
हाँ।
तुम्हारे कुछ बंधु अपने को सुपर पूछने लगते हैं, पढ़े हमारे यहाँ, पास किए हमारे यहाँ, सब ये हुआ, और जहाँ किए डीएम के हमसे ऊपर आ जाते हैं। तो
नहीं नहीं, ऐसा अगर कोई सोचता है तो उसका फुलिशनेस है। ऐसा हो ही नहीं सकता है। ऐसा बिल्कुल नहीं हो सकता सर। हमको पता है कि एक एमडी करके एक इंटरनल मेडिसिन एक फिजिशियन बनना कितना बड़ा टास्क है ये।
लेकिन ये फीलिंग है, नहीं ऐसा बात नहीं है, ये फीलिंग कहीं ना कहीं है।
कोई बात नहीं सर, ये सब तो पार्ट एंड पार्सल है। अब थोड़ा सा एमडी मेडिसिन के बाद थोड़ा एक्स्ट्रा डिप्लोमा भी हो जाता है तो भी उसको फीलिंग आ जाता है, पर ये सब चीजें उतना इम्पोर्टेंट नहीं हम लोग एक्चुअली।
देखो, आ जाना सब बड़ी बात नहीं है, लेकिन वो लोग हमसे सुपर मानते हैं, हमसे अलग रहना चाहते हैं, ये
So, good evening, sir. Good evening, everybody. We have amongst us our Dean, Dr. Professor Kamlesh Tiwari, sir, and it is his initiative that we are having this short certificate course on many other subjects apart from respiratory medicine. That is a very burning subject of internal medicine. And a few words from our professor, Dr. Kamlesh Tiwari, sir.
Thank you, Dr. DP. Actually, every subject is a part of internal medicine, and respiratory medicine is one of them. It is an important subject, and I have given this task to you to conduct the teaching of respiratory medicine throughout the country. The students are joining, they are learning. Still, we have to do this program very vigorously, and we should continue. Today, our speaker is Madhukar, known to us, actually a student of mine, and he will do justice for the students. Thank you, Madhukar. Thank you, DP. Thank you.
Thank you so much.
So today we have Dr. S.K. Madhukar. He is a famous, renowned pulmonologist of Bihar and well known across the country. And he is a very good orator and very impressive. And he has honors and gold medal in his MBBS course. He was the best postgraduate thesis award by the university. He has been the fellowship award by Indian Chess Society in 2020-23. ET Times Award for Inspiring a Respiratory Physician of India in 2024. BT Award for Respiratory Physician in Abu Dhabi. We had seen this clipping from the Abu Dhabi. Uh, Excellence Award in Medicine by RSSDI in 2024. Faculty participation in various national and international conferences. Authored many chapters in API test books and original research publication in thorax and IJCOPD. So let us join hands to welcome Dr. S.K. Madhukar. And today is a very pertinent topic, very important topic in the ICU, in the emergency respiratory medicine. With this, what is the approach of ABG, arterial blood gas analysis? And that is very important. And let us listen the inputs from Dr. S.K. Madhukar, how to approach arterial this blood gas analysis. Over to Dr. Madhukar.
Thank you so much, sir, Dr. DP Singh, sir, for such a kind, introduction. And you have been my mentor, you have been my teacher, you have been my guide. So I have no words to, to describe a personality like you. And I would say that being a course director, no one else deserves, at least in Bihar, to be the course director more than you, sir, for the respiratory medicine. Honorable Dr. Kamlesh Tiwari, sir, who have been my teacher and who is an inspiration for the entire generation of the physician, not only respiratory, but the entire generation of the physician. So it's my honor to be here, and it's my privilege and pleasure also to be here amongst you. What I'll be discussing today is approach to arterial blood gas. I'll just share the slide and okay. Yeah, sir, is the slide visible?
Yeah.
Okay. So arterial blood gas approach. During my postgraduate days, whenever I used to approach arterial blood gas and I would read this in the textbook, I would always confuse myself that how much measurement, data, and everything being put in the report and how I'm going to be at ease to interpret this. Arterial blood gas interpretation is very crucial, not only for the respiratory physician, not only for the critical care physician, but all the physician. And today, I'm going to explain it in a manner that would help us, or that would ensure us to have a bedside interpretation, to have an outpatient based interpretation, so that we can entirely read out what the arterial blood gas has to say. What information do we get from the arterial blood gas? Whenever we have ABG, we get information about gas exchange abnormalities. The first thing that we know from ABG is whether the lung is normal or not. Second information that we get from ABG is acid-base disturbances. So two things: abnormalities of the lung and acid-base disturbances. These two informations we get from any ABG. So what ABG equipment actually measures? There are only three directly measured values by the ABG. The first is pH, the second is PaO2, and the third is PaCO2. So these are only three measurements that are done directly by the ABG equipment. All other measurements are software derived. So we rely on the measurements that we directly observe, or we directly get from the ABG equipment. And these are pH, PaO2, and PaCO2. And you would see that most of the ABG interpretation would be derived from these three measurements only. Is there any call I'm getting from somewhere? Can we? Okay. So in ABG, we will have an integrated two-step approach, because ABG measures two things: lung exchange abnormality, lung gas exchange abnormality, and acid gas. So we'll have two steps. First, for the lung gas exchange. For the lung gas exchange, we need only two measurements. That is PaO2 and PaCO2. If you have PaO2 and PaCO2, you would know whether there is gas exchange abnormalities or not. Second, if you have acid-base disturbances, we would initially need two datas, PaCO2 and pH. So blue line that covers PaO2 and PaCO2 is about the lung gas exchange abnormality. The red square, which covers PaCO2 and pH, will tell us about acid-base disturbance. So let's make it very basic, So how do you evaluate the lung gas exchange abnormalities? So only two datas, PaO2 and PaCO2. When we have the integrated reading of these two, we know we know about the lungs. And how will you have this integrated reading of PaO2 and PaCO2? If you calculate the alveolar arterial oxygen gradient. So what is the difference between alveolar partial pressure of oxygen and arterial partial pressure of oxygen? So when we talk about it in our MBBS days, in our PG days, we always have this equation before us: alveolar arterial oxygen gradient. You can see this equation, very tough to remember. And practically, all of us tend to forget it. Is there any way out? I'm putting a very simple thing before you. that would help you determine alveolar arterial oxygen gradient, whether it is normal or low. And this is the crux of the presentation about gas exchange abnormality. So a very simple alternative to entire equation is rule of 130. What is rule of 130? Very practical approach. Would never get it. If you are, I suppose you are not going to get it in the textbook. So what is rule of 130? Rule of 130 is if your patient is breathing at room air, that is FiO2 of 21%, then if you combine the PaO2 and PaCO2, it should be 130 mmHg. Very simple rule of 130. Add PaO2 and PaCO2, it should be 130, provided the patient is breathing at FiO2 of 21, that is room air. If your patient is on ventilator, if your patient is on an IV or on the oxygen support where FiO2 is high, bring it down for a moment to the 21% and obtain an ABG. Combine PaO2, PaCO2, it should be 130. If PaCO2 and PaO2 addition is less than 130, it means patient is having pulmonary gas exchange abnormality. It is as simple as this. Nothing to remember, no equation to remember. So what would happen? Clinically, I'm telling you something very important. Suppose a patient is having hypoxia. His PaO2 is low. And also, the patient is having hypocapnia, means his PaCO2 is low. So if both PaO2 and PaCO2 is low, then the addition of PaO2 and PaCO2 will be very, very low, much less than 130. Second situation, if your patient is having hypoxia and hypercapnia, his PaO2 is low, but PaCO2 is high, then this addition will still be less than 130, but it is not as low as when patient is having both hypoxia and hypocapnia. So in your clinical practice, if your patient is found to have both hypoxia and hypocapnia, their value is much, much less than 130. Their alveolar arterial oxygen gradient is very less, and they have serious gas exchange problem. These are the patients much more serious than the patients who are having hypoxia and hypercapnia. So this is a practical point out of this in clinical situation. So how will you evaluate hypoxia? If your patient is having hypoxia, if your patient's PaO2 level is low, there are four situations. Either your patient is hypoventilating, or your patient is having VQ mismatch, either because of asthma, COPD, pneumonia. Your patient might have diffusion impairment, for example, for ILD, or your patient can have shunt, for example, pneumonia, ARDS. Number one, if your patient is having low PaO2, but alveolar arterial oxygen gradient is normal, means PaO2 plus PaCO2 is 130. It means your patient's lung is normal. If alveolar arterial oxygen gradient is normal, your patient's lung is normal. And if your patient's lung is normal, and despite that patient is having hypoxia, it simply means that your patient is hypoventilating. For example, if your patient has got CNSA depressant drugs, if patient has CNS depression, your patient if has neuromuscular disease. So lung is normal, but hypoxia is there because patient is hypoventilating. But if your patient is hypoxic and alveolar arterial oxygen gradient is low, means your patient's PO2 plus PaCO2 is less than 130. It means there is problem in the lung. And the problem in the lung can be because of the VQ mismatch, diffusion impairment, or shunt. How do you differentiate between these three? Give the patient oxygen. If the patient receives oxygen for at an FiO2 around 60%, more than 60%, or at least 60%, if you're giving patient oxygen at FiO2 around 60% or more than that, and with oxygen, if arterial oxygen gradient worsens further, means PO2 plus PaCO2 becomes lesser and lesser with oxygen therapy, your patient is having shunt because of ARDS or because of pneumonia. If oxygen therapy improves arterial oxygen gradient, he is not having shunt. He might be having diffusion impairment, for example, ILD or COPD. If your patient, especially emphysema, if your patient with oxygen have normal arterial oxygen gradient or it does not worsen, your patient might be having VQ's mismatch. So clear, hypoxia, PaO2, PaCO2 addition 130, lung is normal, patient is hypoventilating. Hypoxia, PaO2, PaCO2 less than 130. And if you give the oxygen, patient's alveolar arterial oxygen gradient worsens, diagnosis is shunt, ARDS, or maybe patient might be having pneumonia. So it's as simple as this. It's nothing a rocket science. Second part, arterial blood gas evaluates acid-base disturbance also. How do you know the acid-base disturbance? As I told you, for lung gas exchange, we had integrated measurement of PaO2, PaCO2. For acid-base disturbance, there has to be integrated measurement of pH and PaCO2. I have to tell you a 6-step approach for acid-base disturbance. And this is gonna be very, very practical. Again, a very bedside kind of method I'm going to explain. What are those 6-step approach for acid-base disturbance on ABG? The first is assess the internal consistency of the values. What does it mean? The first thing is whether your ABG report is valid for interpretation or not. This is the first thing. And how will you know it? Very simple. Calculate the hydrogen ion concentration. Not a rocket science again. You have the PCO2 value, multiply it by 24, then divide it by bicarbonate. This equation you will have to remember. This is easy. For hydrogen ion concentration, multiply PaCO2 by 24 and then divide it by bicarbonate. That you have to calculate. And this is quite simple, I believe. Now, if your hydrogen ion concentration correlates with the pH, then only this ABG should be interpreted for acid-base disturbance. So if the pH and hydrogen ion concentration are inconsistent, this ABG is not valid and should not be interpreted. You have this chart. I remember putting this chart in the ICU and all. So this much of hydrogen ion concentration, and this should be the corresponding pH. Are you going to remember this? No. Nobody remembers this. Very difficult for all of us to remember this chart. I am giving you a simple trick, and that you have to remember. It's as simple as this. Know this. if you subtract the last 2 digits of pH from 80, that is the hydrogen ion concentration. For example, if your pH, is 7.30, so last 2 digits of pH is 30. Subtract 30 from 80, it is 50. Hydrogen ion concentration is 50. Clear? So last 2 digits of pH, subtract it from 80. That is equivalent to the hydrogen ion concentration. If that is there, your ABG is valid for interpretation. It's very simple thing. Putting an example before you. I have this ABG before you. Okay. So in this ABG, okay. So in this ABG, you have the PCO2 value. You multiply it by 25. And then you divide it by the bicarbonate level. The bicarbonate level is 20. So it comes out to be around 750 by 20. So 37.5. Now you have this pH value. Last 2 digits of pH, subtract it from 80. It's 38. So 38 should be, it's 37.5, almost similar. So is this ABG valid for interpretation? The answer is yes. Very simple trick for you. You are not going to find it there in the textbook, most of the textbook, but this is there. If you remember this, it becomes very, very easy for the bedside evaluation of ABG. Second step for acid-base disturbance. If your ABG is valid, then know whether this is alkalosis or acidosis. If your pH is less than 7.35, it is acidosis. If your pH is more than 7.45, it is alkalosis. So this is the primary disorder. First, look at the pH. What is the pH? Then, remember one thing. Even if the pH is normal, do not discard it as having no acid-base disturbance. For example, a patient with metabolic acidosis and metabolic alkalosis together might have normal pH. So even if the patient's pH is normal, look for the other data. Don't miss it. And the data are PaCO2, bicarbonate, and anion gap. I'm going to tell this. Don't worry about it. So first step, internal consistency. Second step, alkalosis or acidosis. Once you know whether there is alkalosis or acidosis, the next step is try to know whether the disturbance is primary respiratory or metabolic. What is the primary disorder? Is it respiratory acidosis, respiratory alkalosis, metabolic acidosis, or metabolic alkalosis? So what is the primary disorder? Respiratory or metabolic? Again, very simple. Look the direction of change in pH and the direction of change in PaCO2. Remember this, I told you. PaO2 and PaCO2 for gas exchange, pH and PaCO2 for acid-base disturbance. So if the pH and the PaCO2 changes in opposite direction, if pH is high, PaCO2 is low, pH is low and PaCO2 are high. So if the pH and PaCO2 changes in opposite direction, the primary disorder is respiratory. On the other hand, if the pH and PaCO2 changes in the same direction, If pH is high, PaCO2 is high, or pH is low and PaCO2 is low, if the change in pH and PaCO2 is in the same direction, the primary disorder is metabolic. So once you know whether the patient is having acidosis or alkalosis, now you know whether the patient is having primary respiratory disorder or metabolic disorder. So we have reached to the step 3. It's almost complete. Now let's revise step 1 to 3. Very simple. First, what will happen if the patient is having acidosis? First thing is, patient's pH is low, means patient is having acidosis. And if a low pH is associated with high PaCO2, changes in the opposite direction. Low pH is acidosis and PaCO2 is high, change in the opposite direction. So disorder is respiratory acidosis. Second, if pH is low, means patient is having acidosis and PaCO2 is also low. So pH and PaCO2 changes in the same direction. So this disorder is metabolic. And since pH is low, this is metabolic acidosis. If pH is high, this is alkalosis. See the PaCO2. If PaCO2 is low, means change is there in opposite direction. Primary disorder is respiratory. So this is respiratory alkalosis. If pH is high, it is alkalosis. And if PaCO2 is also high, so change in pH and PaCO2 is the same direction. Disorder is metabolic. So this alkalosis is metabolic. This is metabolic alkalosis. Very simple. Primary disorder, we know what primary disorder is there. Now, step 4. I told you 6 steps for the acid-base disturbance. Step 4. Is there appropriate compensation for the primary disturbance or not? If a patient is having primary respiratory disorder, compensation will be metabolic. If the patient is having primary metabolic disorder, compensation will be respiratory. We all know this, very true. Remember, usually compensation does not return the pH to the normal. Don't think that a primary disorder, if being compensated, the pH will be normal. It doesn't happen. If your patient is having primary metabolic disorder, for example, metabolic acidosis, compensation will be respiratory. Even if the compensation is there, pH will be low. For example, pH will be low in acidosis. pH will be high in the alkalosis, even if there is compensation. So please, even if there is compensation, pH doesn't tend to be the norm. How will you remember the compensation? This formula. Again, you get it. I remember this because I do calculate it every day. Even if you calculate it every day, you will remember it easily. It seems to be very exhaustive for you, but I'm telling you, if you keep on practicing, it's not exhaustive. I'm giving you a very simple trick again here. Very simple trick. You are again not going to find it in the most exhaustive textbook. So if your primary disorder is metabolic, to say either metabolic acidosis or metabolic alkalosis. If your primary disorder is metabolic, compensation will be respiratory, right? So when there is respiratory compensation, there will be change in the PaCO2. I told you pH, PaCO2. So when the compensation is respiratory, change will be there in the PaCO2. Very simple trick, remember it. In primary metabolic disorder, last 2 digits of the pH should be the PaCO2. Even if you forget the formula. For example, if in a metabolic acidosis, patient's pH is 7.20, the PaCO2 should be around 20. Is it simple? Yes. So if you have a metabolic disorder, whether it is acidosis or alkalosis, your last two digits of pH will correspond to the PaCO2. Again, simple bedside tricks. Second, if the primary disorder is respiratory, giving you a very simple trick again. If you can remember this formula very well, and you will remember it if you practice it daily, don't worry. But again, I'm giving you the tricks. If the primary disorder is respiratory, for example, then the compensation will be metabolic in the form of change in bicarbonate. We all know this, but we do not remember this. Let's put it very simple here. If your patient is having acute respiratory acidosis, means if it has developed within the first 3 to 5 days, then the change in bicarbonate, what would be the change in the bicarbonate? Acute respiratory diseases, remember one, every 10 mmHg of change in PoCO2 will bring 1 milliequivalent per liter change in bicarbonate. So acute respiratory acidosis, rule 1. Chronic respiratory acidosis, rule 3.5. Every change in 10 mmHg of PaCO2 will bring the change in bicarbonate by 3.5. If it is respiratory acidosis, bicarbonate is going to increase. We all know this. Remember, if it is respiratory alkalosis, acute, every change, 10 mmHg change in PaCO2 will bring 2 milliequivalent per liter change in bicarb, if it is acute respiratory alkalosis. If it is chronic, every 10 mmHg change in PaCO2 will change the bicarb by 5. In respiratory alkalosis, compensation will be decrease in bicarb. Correct? So, you remember metabolic disorder? Last two digits of pH should be PaCO2 and respiratory. Respiratory acidosis, acute, chronic respiratory acidosis, rule of 1, 3.5. Respiratory alkalosis, rule of 2 and 5. Again, simple. No need to put all these formula in the mind. Even if you forget, it's on your fingertips. You can have these tricks to remember the compensation. Why is it important to see the compensation? If the observed compensation is not the expected compensation, you know that this should be the compensation. But then you check the bicarb, then you check the PaCO2, and it is not equal to the expected compensation, then it is likely that the patient is having more than one acid-base disorder. And this is the clue to the presence of more than one acid-base disorder. You want to see it? Yeah. Let's revise step 1 to 4. And it will be very, very easy for us, all of us. See here. Suppose an example. If your patient's pH is 7.5, the primary disorder is 7.5, it is alkalosis. And when you have the pH 7.5, you will see the change in PaCO2. Here the PaCO2 is 48. So pH is high, PaCO2 is high. PaCO2 should be between 35 to 45. If your pH is high and PaCO2 is high, change in pH and PaCO2 is in the same direction. When the change in pH and PaCO2 is in the same direction, the primary disorder is metabolic. So the patient is having metabolic alkalosis. Now, see the compensation. If the patient is having metabolic alkalosis, the compensation would be in the form of change in PaCO2, right? So what should be the compensation in metabolic alkalosis? What did I tell you? See the last two digits of pH. It is 50. So what should be the PaCO2? It should be around 50. And PaCO2 is 48, almost there. So this has been the compensation. And if the observed compensation is equal to, almost equal to the expected compensation, then there is no mixed disorder. It's simple primary metabolic alkalosis. I hope you got it. Second example, let's revise it again. pH 7.12. So pH is low. Normal pH is 7.35 to 7.45. pH is low. Here PaCO2 is 32. Normally it should be 35 to 45. pH is low, PaCO2 is low. So change in pH and PaCO2 is in the same direction. If the change in pH and PaCO2 is in the same direction, primary disorder is metabolic. And pH is low, so it's metabolic acidosis. So when there is metabolic acidosis, see again the compensation. In metabolic disorder, I give you a trick. The last two digits of pH, 1, 2, should be the PaCO2. Because metabolic compensation will be respiratory, PaCO2. But look at here. The last two digits of pH is 1, 2, and PaCO2 is 32. So PaCO2 is much, much higher than the expected compensation. So observed compensation is much greater than the expected compensation. So PaCO2 is much higher. So when PaCO2 is much higher, it is respiratory acidosis. The patient is having combined metabolic and respiratory acidosis. I hope it's becoming very clear to all of you. Let's go to see the last example. Let's make it clear once again. Here I am putting a story. A 24-year-old man found unconscious on the floor, which was soiled by his vomit. And he was last seen 4 hours prior and appeared well at the time. Fine. pH 7.34. So pH is low. It should be 7, it's less than 7.35. So pH is low. PaCO2 is 65, much higher. It should be 35 to 45. PaCO2 is much higher. pH low means patient is having acidosis, and change in pH and change in PaCO2 is in the opposite direction. So the primary disorder is respiratory. So the patient is having respiratory acidosis. Now, see the compensation. See whether the respiratory acidosis is acute or chronic. Patient was well 4 hours prior. So it is acute. If the patient is having acute respiratory acidosis, I told you, rule of 1, acute respiratory acidosis. Every 10 mmHg change in PaCO2 should bring change 1 milliequivalent in bicarb. So PaCO2 is 65. Even if you divide it by 10, it's 6.5. Correct? So 6.5 plus 8, almost 14.5. Look at the bicarb. It's 34. Much, much, much higher. So expected compensation is much higher. Observed compensation is much higher than the expected. So it means the patient is not only having one disorder, he's having combined acid-base disorder. So this patient was having respiratory acidosis. Now compensation was supposed to be around 14, it has become 34. So it has metabolic alkalosis. So this patient is having both respiratory acidosis as well as metabolic alkalosis. So a combined disorder. I hope with these 3 examples, I could make it clear why knowing compensation is important. Because knowing compensation makes us to discover the combined acid-base disorder. And step 5, Just 2 steps is remaining. Step 1 to 4 are applied in all the acid-base disorder. Step 5 and 6 applies only when your patient is having metabolic acidosis. If your patient is not having metabolic acidosis, then step 5 and step 6 are not needed. So if your patient is having metabolic acidosis, calculate the anion gap. It's very simple. Anion gap is sodium minus chloride plus bicarb. So chloride and bicarb, you add them and subtract it from sodium. So measure anion is subtracted from the measure cation. Normally, anion gap has to be 8 to 12. So we take 12 as the reference value of anion gap. So if your patient is having metabolic acidosis, go for the anion gap. But at the same time, if you're looking for the anion gap, always look for the serum albumin. So if your patient is having metabolic acidosis, you have to measure 2 things, anion gap and serum albumin. Why is it important? Because if your patient is having low serum albumin, the anion gap is going to be lower. And there is a very simple thing. For patients, every 1 gram per deciliter decrease in plasma albumin from 4. Suppose 4 is the reference of plasma albumin here in the equation. Every 1 gram deciliter decrease in plasma albumin from 4, the anion gap would decrease by 2.5. Simple. If your patient's plasma albumin is 2, for example, the anion gap will decrease by 5. So every 1 gram decrease will bring 2.5 milliequivalent decrease in the anion gap. And this is important. You cannot interpret anion gap without albumin. So whenever you have metabolic acidosis, calculate the anion gap and calculate the albumin. Now, there are certain common causes of high anion gap metabolic acidosis. Renal failure, diabetic ketoacidosis or alcoholic ketoacidosis, lactate acidosis. If these 3 are there, these are the commonest cause of high anion gap metabolic acidosis. Diagnosis there, don't worry. But remember one thing, if your patient is having high anion metabolic acidosis and you are not finding the common cause, patient is not having diabetic acidosis, not alcoholic ketoacidosis, not lactate acidosis, not even renal failure, what did you do? Clinical situation, high anion gap metabolic acidosis. Calculate the osmolar gap. Is it, even if you don't calculate the osmolar gap, you can have it in clinically. So osmolar gap is measured osmolality from calculated osmolality. Not very difficult to remember. We all have been, trained in our PG days. If your osmolar gap is more than 10, it means toxic ingestion. What we do practically in the ward? If we get high anion gap metabolic acidosis, we do not find ketoacidosis. You do not find ketones in the urine, correct? We do not find raised blood urea nitrogen and creatinine. We do not find patients, lactate level high. We start thinking of toxic ingestion. Commonest are ethanol intoxication, methanol intoxication, isoniazide salicylate paraldehyde intoxication. A very simple clinical clue. And the last step, and this step applies if your patient is having high anion gap metabolic acidosis. See the neutrality of anion gap. Last step, but very important. If there is an increase in anion gap, then see whether this increase in anion gap has been neutralized by decrease in the bicarb or not. This is called delta ratio. Very simple to calculate. Change in anion gap divided by change in bicarbonate. Usually, whatever change in the anion gap is there, there should be almost similar change in the bicarbonate. If your patient's delta ratio, normally it has to be 1 to 2. If your patient's delta ratio is less than 1, if delta ratio is outside the range, then remember another metabolic disorder is present, not respiratory. Metabolic disorder is present. So if delta ratio is less than 1, so there is high anion gap metabolic acidosis as well as normal anion gap metabolic acidosis. If delta ratio is more than 2, it means the patient's anion gap changes more, then there should be decrease in the bicarb. So if delta ratio is more than 2, it means the patient is having high anion gap metabolic acidosis with metabolic alkalosis. Very simple. High anion gap metabolic acidosis is always there. You see the ratio between change in anion gap and change in bicarbonate, that is called delta ratio. If it is less than 1, it should be normal 1 to 2. Less than 1 means there are two kinds of metabolic acidosis, high anion gap as well as normal anion gap. If delta ratio is more than 2, it means the patient is having high anion gap metabolic acidosis with metabolic alkalosis. So let's revise. Very simple thing again, putting some practical point. If I'm getting the time, if it's okay. Yeah, I'm just having 10 minutes. So I'm just putting some examples to make the things very clear. 75-year-old female presented with fever and died, yeah? And the vitals are there. Look at the ABG. pH 7.29. pH is low. So the patient is having acidosis. Primary disorder is acidosis. See the PaCO2, it is 30. Normally, PaCO2 should be between 35 to 45. pH is low, PaCO2 is low. Change in pH and PaCO2 is in the same direction. So, the primary disorder is metabolic. The patient is having metabolic acidosis. Next step is see the compensation. Compensation is if the patient is having metabolic disorder, last two digits of pH should correspond to the PaCO2. So last two digits of pH is 29. What should be the PaCO2? It should be around 29. So it's compensated. Correct? So the patient is having primary metabolic acidosis. If the patient is having metabolic acidosis, what should be then? We should go to the step 5 and a step 6. So step 5 is if the patient is having metabolic acidosis, look for the anion gap. And what is the anion gap here? Bicarbonate plus chloride. Bicarbonate is 14, chloride is 94. So it is 108. And then subtract it from sodium. So it's 20. Anion gap is 20. What should be the anion gap normally? 12. It is 20. So this is high anion gap metabolic acidosis. Clear? Yeah. Then what would you do? If there is high anion gap metabolic acidosis, last step, step 6, delta ratio. Change in anion gap. Anion gap is 20. So what is the change in anion gap? From 12 to 28. Divided by change in bicarb. Normally, the bicarb should be 24. Change in bicarb. Here bicarb is 14. So change in bicarb is 10. What is there? So change in anion gap, 9. Remember? So change in anion gap is 8. And here the change in bicarb is 10. So it's 0.8. So delta ratio is less than 1. If delta ratio is less than 1, the patient is having high anion gap metabolic acidosis and also non-anion gap metabolic acidosis. And management is going to differ. I'm telling all these things because you have to clinically manage the patients. You are just not going for the high anion gap. You also need to think about the normal anion gap metabolic acidosis. A second example. I'll just take for 5 minutes. I'll be done with it. So I'm revising step 1 to 6. 48-year-old alcoholic found unconscious in apartment, soiled with vomit. He was leaving party 6 hours prior. So before he was in the party, and after 6 hours, he was found unconscious and soiled with the vomit. pH 7.17. pH is low. The primary disorder is acidosis. Then what will you see? PaCO2. PaCO2 is 65. So pH is low, PaCO2 is high. Change in pH and PaCO2 is in opposite direction. So primary disorder is respiratory. So the patient is having respiratory acidosis. Go for the compensation. This respiratory acidosis is acute because the history of 6 hours. So it's an acute respiratory acidosis. Rule of 1. Every change in 10 mmHg of PaCO2 will bring 1 milliequivalent change in bicarb. So here 65 by 10, 6.5 plus 8, 14.5. Bicarb should be 14.5. It's 22. So bicarb is high. Compensation is not equal to the expected. So the patient is having higher bicarbonate level that has to be than the expected one. So the patient is having combined respiratory acidosis with metabolic alkalosis. Combined respiratory acidosis with metabolic alkalosis. Correct? So, to summarize, what are the 6 steps in acid-base disorder? Check the internal consistency. See whether it is acidosis or alkalosis. Then see whether this acidosis is alkalosis is primary respiratory or metabolic. See the compensation, whether the compensation indicates more than one acid-base disorder or not. And if the patient is having metabolic acidosis, calculate the anion gap. And if the patient is having high anion gap metabolic acidosis, check the delta ratio, that is change in the anion gap by change in bicarbonate, less than 1 or more than 2. I hope I could make some kind of sense to such a complicated topic in the last 1 hour. Thank you so much. Thank you so much for your patience listening. I hope you have got something out of it, especially the tricks that I have given to you that you are not going to find in your textbook. It's going to help you for the bedside evaluation of ABG. And if you have got all these things together, I believe I've done my justice. Thank you so much. Thank you so much, Dr. D.P. Singh, sir.
Excellent deliberation and very much the tips. That's very, very important to remember. And before we close, there are some of the questions. First one is, what are the causes? See the chat box, Dr. Madhukar.
Okay,
What
sure,
are
sir.
the causes of normal anion gap acidosis in routine ICU and what is it?
Okay, sir. I'm just
Ward cases?
a second, sir. Just a second. Just a second. I'm just leaving the page and I'm going to the questions. Give me a second. I'll do that.
Mhm.
Okay. So is it in the chat box, right, sir? Uh, So what was the question, sir? I'm not able to see. Just can you just please put the question, sir? So leading causes of normal anion gap metabolic acidosis, I guess it has been asked. Yeah. So the leading cause of normal anion gap metabolic acidosis that we usually see, the most common cause is diarrhea. So the leading cause are diarrhea. The second, if the patient is having renal tubular acidosis. And the third, if your patient is receiving normal saline infusion. These are the three commonest leading cause that we practically see in the ward for the normal anion gap metabolic acidosis. Sir, can we have another question, sir? Sir, I'm not able to hear you. Can you just still not able to hear? Yeah, sir. No.
Yeah.
Okay, sir. Next.
What are the common causes of metabolic alkalosis that we encountered in ICU and wards?
Yeah. So metabolic alkalosis common causes. If the patient, your patient is having profuse vomiting, patient is having rise to aspiration, then your patient if are receiving diuretics, if your patient is on ventilator, so it's and the patient is having hypercapnic, so post intubation hypercapnic or post ventilatory hypercapnic situations. So these are the leading situations where we get the metabolic alkalosis.
Excellent. Please add a note on common causes of respiratory alkalosis and metabolic acidosis.
So I guess he's
Respiratory
asking,
alkalosis and metabolic
so
acidosis.
I guess he's asking the situations in which respiratory alkalosis is going to coexist with metabolic acidosis.
Metabolic
So let's
acidosis.
first see what are the situations in which the patients can have respiratory alkalosis. The common cause of respiratory alkalosis are if the patient is hyperventilating because of the any cause. Is it anxiety, panic, pneumonia, even liver cirrhosis, the patients of renal failure? No. See, among all these things, where the patient is going to fit to have metabolic acidosis, patients with liver cirrhosis is likely to have respiratory alkalosis as well as metabolic acidosis. Patients with renal impairment is likely to have respiratory alkalosis with metabolic acidosis. Your patient is having diabetes, goes on to develop pneumonia, goes on to develop diabetic ketoacidosis, respiratory alkalosis with metabolic acidosis. So these are the situations we need to really think about these things, and you will decipher that, yeah, these two common disorders are present based on the ABG. Even your
Another
patient
is
has heart failure. For example, if your patient is having heart failure with the renal failure, respiratory alkalosis, heart failure, respiratory alkalosis, renal failure might lead to high non-gap metabolic acidosis. Another situation. So there are a lot of situations there where respiratory alkalosis can be there with metabolic acidosis.
again this Satija. These are all questions from Dr. Satija. And the next question is how to manage type 2 respiratory failure in acute exacerbation of COPD. That could be the very common.
I understand. I'm telling you, I have been focusing on the interpretation only. But since this question has come to me, I'll take this opportunity to briefly answer your question. In a COPD patients, if your patient is having type 2 respiratory failure, unless your patient is having contraindication of NIV, your patient should receive NIV support together with the treatment of the underlying disease if the patient is not having contraindication to NIV. For NIV, it leads we need to understand that the patient should have adequate pressure support so that the patient's hypercapnia can be reduced, and patient should have adequate EPAP so that hypoxia should be addressed. I guess we are going to, can someone mute himself, please? Yeah. So this is the situation. If your patient does not have contraindication to the NIV and the patient is having type 2 respiratory failure in COPD, NIV should be supported with the baseline therapy. But if the NIV fails or the patient is having contraindication to the NIV, then those patients should receive invasive ventilation with underlying therapy, with therapy for the underlying disease.
Thank you, Dr. Madhukar. And Dr. Neha is usually frequently asked questions. And her questions are two. There is one, why if there is a mismatch in ABG and serum electrolytes, which should be considered appropriate?
Uh, of course, Miss, I guess, why electrolyte
Neha,
somewhat
Neha Kumari, if there is a mismatch in ABG and serum electrolytes, which
yeah.
one is more
Let,
appropriate?
let's understand this very
And even why there is differences in their, yeah.
correct. Let's understand this fact. APC is never meant to measure electrolyte. Your ABC equipments measure only three things directly. One is pH, PaO2, and PaCO2. Your ABC doesn't measure anything else. Whatever measurement others you see in the ABZ is the derived measurements based on equation from the software. So these are the not direct measurement. And this is why these measurements are prone to have error. For bicarbonate, we know we have this Henderson equation. We have this Henderson-Hasselbalch equation for the bicarb. So we can calculate the bicarb based on pH, PaCO2, PaO2. But what about electrolytes? These are not directly measured. These are software derived. So we need to measure all other measurements from the separate venous or arterial blood.
And so that gives the answer that will we correct potassium in ICU according to the corrected potassium to pH or serum potassium? Serum potassium,
Yeah,
it's more
because these
important
are
than
not the
that.
direct measurements. Your software giving these measurements.
And then another is Sateja again. What are the basic changes to be added to ABG to get accurate value and avoid repeated ABG? What is this?
What are the basic changes to be added?
Basic changes
I'm
are
not.
the basic changes
What are the?
to be added to ABG to get accurate value and avoid repeat ABG.
I don't know what is the question is. I actually not getting it, but I guess avoiding repeated ABZ. I'm sure your repetition of your ABZ is dictated by the clinical situation of the patient, and it's not harm if you repeat the ABZ, provided the clinical situation dictates that, because you would like to know whether the patient is improving with your therapy or not. So getting repeated ABZ, we all repeat the ABZ to know what how the patient is responding to the given treatment.
Uh, what is the venous blood gas? What is the VBG? Is there a way to derive ABG value from venous blood gas?
This is an important question. You remember the step one, the internal consistency of ABZ value? That is there. If you have an ABZ, the first step is to check the internal consistency of your value. Calculate the hydrogen ion concentration, 25 into PaCO2 by bicarb. And if your hydrogen ion concentration is equivalent to the 80 minus last two digit of pH, I gave you the trick. You remember the first trick that I gave you. If it is there, you know this is arterial blood gas sample and it is consistent, you have to go ahead. If it's not valid.
So that's the end of this today's talk, Wednesday master class from master teacher Dr. Madhukar upon the approach to ABG. Thank you very much, Dr. Madhukar, and thank you all the listeners, all these delegates that who have attended it. Thank you very much. And we are hoping that we shall get this all these things in the book form. And so be ready for that. Yeah.
Yeah, sure, sir.
Thank you.
We'll
Thank
do
you.
that for all of us, colleague. And Thank you so much, sir,
Thank you.
for asking me to be here, and I really enjoyed the session. Thank you so much, sir.
Okay. Thank you. Thank you again.